My name's Latesha Elopre. I am one of the principal investigators for this study. I work with Len Matthews, and today I'm going to talk to you specifically about how you prescribe PrEP and then how you can be a PrEP champion, which I always feel like there should be like superhero music and like a cape flowing because PrEP champions are so important in regards to helping people be able to prescribe. So we're going to go over just some basics about PrEP prescription. And at any point in time, please feel free to stop me and ask questions. Okay, so the learning objectives for today, you're going to understand the benefits of PrEP overall for the adolescent population, specifically those living in Alabama, as somewhat of a call to action. You're going to understand how to start patients on PrEP and then how to continue them on PrEP and do follow-up care. And then we'll review some of the different modalities, meaning the different types of PrEP medications that are currently FDA approved and who they're indicated for, because that differs. The sexual history aspect of this, which many of you will understand, the first aspect of being able to offer anyone PrEP is taking a sexual history, will be offered later next week by Dr. Samantha Hill. Okay, so why is this so important? All of you on this call are providers, so I think a lot of you already understand that adolescents right now are especially, I think, a population where we care about sexual health and the idea of promoting things like STI and HIV testing. And this isn't something that everyone had already been aware of, I think, maybe decades ago. But if you were to look at just national cohort data, trying to understand general trends, and we collect this really every few years, we now know that in 2016, Alabama ranked 9th in the nation for teen childbearing. So 28 births out of 1,000 teen girls between the ages of 15 and 19. We're trying to do better with teen pregnancy, and we have over the past few years, but this is still something that I think is shocking to understand, that not only are our youth, especially in the state of Alabama, having sex, but they're also having pregnancies during this age. In 2015, among those surveyed in this youth risk behavior survey, 46% of Alabama high school students reported ever having sex. And then 35% of Alabama high school students reported being currently sexually active. And then 70% of Alabama high school students reported being currently sexually active and not using birth control. An IUD, implant shot, really just nothing. And then 49% did not use a condom. And I think that this really is the aspect where we really want to focus on and be able to promote sexual health. The idea of trying to understand what reproductive goals are, especially when you're an adolescent, and understanding how to protect ourselves from STIs and HIV. So this is just that data from 2019, same kind of survey broken down a little bit more granularly. And you can see this separated by male versus female, and then overall of those who reported currently having sex. And then in the framing of this talk today, looking at those who had actually taken action and done some HIV prevention, STI prevention behavior that was positive in regards to testing, was really minimal. So in the same group, only 22% of men had ever been tested for an HIV. Only 18% of young girls had been tested for HIV. And then looking at STI testing, those rates mirror. So now look at the counter. When we're talking about who's actually being diagnosed with HIV, in our state, the group that is most likely to be diagnosed is the age of 20 to 29. So that's really late adolescence to early adulthood. This is diagnosis. This is not when they acquire it. Most likely, a lot of these diagnoses actually are happening later, and they're acquiring this infection when they're adolescents in this age of 13 to 19. So our ability to talk to our youth at probably even younger ages than what we're presenting on today is crucial. The other aspect that we really want to highlight with this talk is that there are these differences in regards to age range, and that's why we really, for our study, want to focus on adolescent populations, but also there are differences in regards to race and ethnicity as to who most likely is going to be diagnosed with HIV. There's many factors that are contributing to this. A lot of it has to do with structural factors that are current and historical that make it harder for Black individuals and Hispanic individuals to access services in an equitable fashion. But within 2019, we know that Black women were 10 times more likely to get diagnosed with HIV compared to white women, and Hispanic women were almost 4 times more likely to receive that diagnosis, which is why our study also focuses on making sure that our messaging is inclusive and specifically tailored to make sure that it's culturally appropriate for these populations, and specifically for Black women. So let's focus on HIV prevention. For our state alone, there are some counties that bear the highest burden when it comes to who's most likely to be diagnosed and in which geographic area. You can see here that the one county that's actually seeing increased rates is Mobile. So there's been a lot of efforts to try to understand how we can improve that. And Tuscaloosa has also seen a slight rise, not as high as Mobile, but still concerning. We also have some pretty pronounced disparities in who's being diagnosed with HIV. And you can see really in this bottom row, Black non-Hispanic individuals are the most likely to be diagnosed with HIV within our state. And that is based for really all gender types. And then the second really, I think, risk factor when we look at who's most likely to be diagnosed is also by type of sex that you engage in, because we know that for anal exposure, it's very high. The reason why we're focusing on vaginal exposure for this talk is because we think it's also under-recognized. So HIV prevention has a lot of different ways that you can think about it. And in the past, we really thought about it really only after someone was diagnosed did we start really caring about HIV. And there was a shift in the framework where we said that we wanted to really care about communities and populations that we just discussed that we knew that were the most vulnerable to be diagnosed. And that's the status neutral approach, where you're trying to understand how to improve HIV prevention among communities that are most greatly impacted. That's coming through the point in which someone's HIV tested, which hopefully we're doing comprehensive testing. And then if someone tests positive, we're quickly engaging them to effective antiretroviral therapy, because we know that once you're linked to therapy, if you stay in care and engaged, if you're virally suppressed, you cannot transmit the virus. So that is treatment as prevention in and of itself. 0 transmissions, undetectable equals untransmittable. If you test negative, then you're really doing a lot of counseling around sexual health, and you're talking about other options in the toolkit. And other options in the toolkit are things like condoms. If someone's reporting injection drug use, we do not have a syringe exchange program in our state, but other states do, and that's a part of the toolkit. Talking about things like post-exposure prophylaxis, and then specifically for our study, what we're going to teach you about is pre-exposure prophylaxis, or PrEP. So PrEP, the first PrEP modality, TDF-FTC or Truvada, was approved by the FDA in 2012. So it's been greater than a decade. In 2018, it actually was approved for adolescent populations, and that is weight-based. So for that study, you had to be 35 kilograms or above, and so that's 77 pounds. There are a few different formulations of PrEP, but the one that we are focusing on is this tenofovir disoproxil fumarate, amitriptyline. So that's the 2 components, TDF and FTC, that's in this drug that makes Truvada. And the goal is that if you take this really enough, you're adherent enough, then it is 95% effective in preventing HIV acquisition if you were exposed. So highly effective. We used to have a slide that really showed that there has been several clinical trials in serodiscordant couples that have shown that transmissions really did not occur, especially when they did open label and followed couples over time. So we know that this is effective. Specifically, there is one trial that happened among adolescent populations that led to FDA approval, and that's the ATN 113 trial. This trial specifically focused on 78 gay and bisexual adolescent men who have sex with other men and trans women who have sex with men. And the only drug they looked at for this trial specifically was Truvada, so oral PrEP. The big things that they looked at, which some people get concerned about, are things that we know TDF-FTC or Truvada can do if you have unhealthy kidneys. So looking at a rise in your creatinine, looking at shifts that can occur in bone mineral density, because especially the tenofovir aspect of this can affect your bone health, and acceptability and adherence over time. And really what this is just showing you is what the demographics for the study looked like to the right. So you can see that it was a fairly diverse group of individuals that they included in the study, and individuals who were engaging in sexual activities that could make them more likely to be diagnosed with HIV. So individuals who reported sex in exchange for goods or necessary needs, people who had been kicked out of their homes. 60% had condomless receptive anal intercourse. So in regards to safety outcomes, everything actually turned out great, which was wonderful. TDF-FTC does cause weight loss. 2 participants in this trial reported weight loss, about 10 to 19% of their weight being lost. If you stop TDF-FTC, this goes away, and most people, it's not clinically significant. There were no other lab abnormalities. Bone health was fine. Kidney function was fine. They did have 3 seroconversions in this group, and it was all due to poor adherence. And what they did find with this study, which I think is a crucial aspect because this is the population that we're specifically wanting to make sure that you're empowered to prescribe for, is that adherence waned over time. So specifically for anal sex, we know that we want to at least get 4 doses in a week. And that is our goal. That's going to protect you. Only 60% of adolescents were able to do that. And then if you look at this chart on the right, you'll see that there were a lot of reasons why they said that they weren't able to do it. They had a change in routine. They were away from home. They were too busy. They just forgot. So adherence counseling is huge. And especially as we follow people over time, because adherence actually in this population got worse over time. So that is all of the why we're doing what we're doing. And we're going to shift now to what we're hoping you'll feel empowered to be able to do after this. And that's prescribing PrEP. So the first big thing we want to make sure you're all aware of is PrEP, pre-exposure prophylaxis, should be something that you educate all of your patients on, adults and adolescents who report that they're sexually active. And that's a CDC recommended guideline. So anyone that you're doing a sexual history on, they say, I'm engaging in sex, you should be educating them about what HIV pre-exposure prophylaxis is as a part of their sexual health toolkit. The CDC also came up with this algorithm, and I'll walk you through it, that really tells you what individuals you probably should discuss PrEP in more detailed aspects in hopes that you will be able to prescribe for. But again, everyone should be educated, and anyone who asks for it, you should prescribe. So anyone who reports that they are sexually active, you should ask the gender of their sexual partners and know if they're engaging in anal, vaginal, oral sex. If they've had anal or vaginal sex in the past 6 months, I'm going to take you down the yes side of this tree. The biggest things we're looking for is what we know are predictors of future HIV diagnosis. So yes, I've had anal or vaginal sex in the past 6 months. My partner was living with HIV, and I did not know if their viral load was undetectable. So they may not have been on ART or therapy for their HIV. If that's the case, we know that this individual may be more likely to be diagnosed with HIV in the future. So you would prescribe PrEP for them. If the person says yes, and they report 1 or more sexual partners, and they do not know their HIV status, and they're not always using condoms, then yes, this is someone that you potentially would want to prescribe PrEP for. And then last, had a bacterial STI in the past 6 months. This is something that will differ based off if you're talking about men who have sex with men, which is what MSM stands for, men who have sex with women, or women who have sex with men. So the STIs that we know that are most likely to predict future HIV infection among men who have sex with men but really almost all of our bacterial STIs, gonorrhea, chlamydia, and syphilis. These are yes, we should prescribe PrEP. For those who've had a bacterial STI who are men who have sex with women or women who have sex with men, gonorrhea and syphilis have been the two STIs that we know are more likely to lead to future HIV diagnosis. So all of these indications should kind of have your spidey sense tingling, and you should think, okay, this is someone I may want to have a more detailed conversation with and say, PrEP may be a good option for you. But again, everyone that is sexually active, all patients who engage in vaginal anal sex, you should be discussing PrEP with. Okay, so before you initiate PrEP, what are the things that you need to do? So you've already gone through your decision tree, you understand, you've done your behavioral assessment. Based off of our local epidemiology within the state of Alabama, we kind of went over counties and age groups. You know that just having sex with one person within our county can lead to an HIV diagnosis. In fact, it's always sex with one person, right? That usually leads to an HIV diagnosis. So we want to be empowering and destigmatize the idea of someone accessing PrEP services. So again, we do a holistic approach. We have this discussion with them and say, this is something I talk with all of my patients about who are sexually active. And I want you to feel empowered as a patient to potentially use this as a prevention tool for you. If they are agreeable, you're going to want to get an HIV test. And that HIV test is going to need to be within 1 week of you starting PrEP, because we don't want to start PrEP on somebody who has HIV. You should also screen them for acute signs and symptoms of HIV. That's usually a mono-like illness we typically describe, where you have fevers, chills, people can report that they have nausea, vomiting, diarrhea, or a rash. And then the HIV test that we usually send off, and what is recommended by the CDC, is a 4th generation antigen antibody test, and then a viral load. You confirm that they are okay to be able to take oral medications. And the biggest thing that we're going to look at is that creatinine clearance. So you're going to want to get a creatinine as well. The other tests that we really want to look at are things that we know TDF, FTC, or Truvada treats, and that's hepatitis B. So we want to screen for hepatitis B infection. If you have hepatitis B, that doesn't mean that you can't get PrEP. It just means that we want to counsel our patients that this medication is something that actually treats hepatitis B, and that in rare instances, if we were to stop this medication, people could have a flare of their hepatitis B infection. We don't really see that except for in people living with HIV. And some people actually think, and there have been studies that have shown that this risk is actually super minimal, but we still educate people about it. You also want to screen and treat any STIs, and then do a pregnancy test. This is safe for women who are pregnant, or any persons who are pregnant, but we still want to document the pregnancy test and provide contraception if it's desired. Okay, so this is our fun table that talks about the PrEP options. Unfortunately, not all populations have been included in all of the different types of PrEP modalities. And that is why we provide this table for you, because I'm sure many of you have heard about TAF, FTC, or Descovy, which is in the second column. And there's our long-acting injectable, which is Apretude or cabotegravir. Truvada is great because it's approved for all populations, including adolescents. The biggest thing is that you have to have a normal kidney function in order for you to receive it. So this is approved for people who inject drugs, for vaginal sex, for anal sex, for adolescent people, for pregnant people. That's why this is the main modality that we're really educating on for this talk. Tenofovir alafenamide is a drug for tenofovir, but it is not approved for all populations. It's not approved for cisgender women or vaginal exposure because this population was not included in the trials. It's not approved for pregnant women, and it's not approved for injection drug use. But you'll see here that your creatinine clearance can be lower for Descovy. So the populations that can take this really are transgender women, and then cisgender men and transgender men. So anyone who's engaging in anal sex. You can also have some people engaging, and this is recent, in insertive vaginal sex, and then transgender women engaging in insertive or receptive anal sex if they have affirmative surgeries and they've now had estrogens on board as well. Those populations have been included, although minimal in trials, and you can provide Descovy for them as well. And then the cabotegravir is our new one. This is a little bit harder to administer from an implementation standpoint because of difficulties in being able to acquire the medication, which is why we are not really going to focus on this for this talk, but we have provided some easy, I think, websites that have really good online tutorials if this is something you're interested in implementing in your clinic. But this is approved for all populations except for people who inject drugs and pregnant women. And this is really a shot. It's in the butt, it's large volume, and you do it every 2 months. So if you're making a decision between your two oral options, Truvada or Descovy, you're going to look for, number one, sex at birth. If they are female, all you have is Truvada. If it's someone who's male, you have several different options. So you want to think about things like, do they have chronic kidney disease? Do they have osteoporosis? Are there other risk factors? Typically, if someone has chronic kidney disease or osteoporosis, I will say, maybe we should do Descovy in you, especially chronic kidney disease and osteoporosis, because we know that Descovy or tenofovir alafenamide is protective. Hyperlipidemia and weight gain are the main side effects of Descovy. We actually have to check a lipid panel once a year if someone's on Descovy. So if that's the case, I will actually say, everybody else, just give Truvada. Okay, so once you decided what type of PrEP you're going to give, the biggest thing you want to remember is that you write your prescription, you give them 30 tabs with 2 refills. You're going to give them a 90-day supply, and they're going to come back and see you every 3 months. You also want to talk about cost, because cost is probably the biggest barrier. This was given a grade A designation, so there should be zero cost savings associated with any type of PrEP modality that you're offering. But people will still sometimes get stuck with copays, even though they're not supposed to if they have insurance. So I always tell people, if that occurs, please come back to the clinic and let us know. Sometimes you have to call the insurance companies, and then there are also maybe prior authorizations that you have to complete. So we want to show you this data just so you're aware for the reason why now you have to, when you're doing follow-up visits, also get a viral load. And that's because with the long-acting injectable, you actually had people who seroconverted when they were being adherent to the medication. So in this trial that looked at long-acting injectables, specifically among men who have sex with men, they found 12 people who were infected, and 6 of which actually developed what we call INSTI resistance. So integrase resistance, which is bad because that's one of the major medications that we use for people who are living with HIV. So you're taking away a whole class of medications. And so our goal, especially if you're doing long acting, is to make sure that we detect any HIV seroconversions, although they may be rare, earlier, because the earlier you detect an HIV seroconversion, the least likely that virus will change and you'll get any type of mutation in the virus, losing a class of drugs for the future. Okay, so we provided this one last table that really is a nice summary of eligibility, because we want to make sure that you had a clear pictogram, if that's a word, of what you can prescribe and for whom. So really, again, green light for anything related to Truvada. Truvada is amazing. It's been approved. It's FDA approved since 2012, so it's been around for greater than 10 years. And it was used in studies that included all populations, including only the one trial that we had that included people who injected drugs. Some of your patients may ask you about on-demand PrEP. This is only approved for anal exposures, and that's taking 2 pills of Truvada 2 hours before before anal sex. And then you take one pill 24 hours after that, and another pill 48 hours after that. That's why it's called 2-1-1. This is not actually an FDA approved use, but there are guidelines saying that you can prescribe it off label. Descovy is green lit for everybody except for people who inject drugs and for pregnant women. And then not for cisgender women. And then injectable cabotegravir again, green lit again, except for people who inject drugs and for pregnant women. So clinical monitoring during oral PrEP. After you started someone off that initial regimen, whichever one you choose, you're going to get, remember, the HIV antibody antigen and HIV RNA testing, the STI testing, the hepatitis B serology. In some populations, we recommend hepatitis C serology, specifically for men who have sex with men, transgender women, and especially for people who inject drugs. You check their renal function. If you're prescribing Descovy, you check a lipid panel. And then we do adherence counseling for everybody. That's your first visit. Then after that, your 3-month visit, it's really just STI testing for people who are reporting anal sex. And then you can do an antigen, antibody, and RNA test or viral load test at the 3-month visit. Then at 6 months, STI testing. There should be a check here because you're going to be doing this again every 3 months. And I think the reason why they didn't put a check and we didn't put a check is because it's every 3 months. So just for a clarity's sake, you do this at every visit. HIV antigen antibody testing. The only time you have to check every 6 months for renal function is in somebody who's greater than 50 years old. If they're less than 50 and their creatinine clearance is greater than 90, you actually will have to check it once a year. So that's great. And then remember, for people who are on Descovy, you check that lipid panel once a year. This is clinical monitoring for cabotegravir, which is our injectable option. Remember, we just included this in here in case some of you really want to offer this. I think it's wonderful. And if you have additional questions regarding this, please let us know. So what are the adverse events that can happen when you start someone specifically on Truvada? And I put this up here because this should be a part of the counseling, especially that you talk to your patients about. The ones that they're going to see commercials about that people are going to ask you potentially about are kidney toxicity and bone density loss. There were some lawsuits a while ago in regards to TDF. And again, this is not occur in people who are having normal renal function and healthy bones. So this really should not happen. In individuals who have a history of smoking, they're greater than 55 years old, and they have other risk factors, this is not something that you would probably offer for them. The other thing that I counsel all of my patients on is that they could potentially have some startup symptoms that last at most a month. The ones that I hear the most about is nausea. Some people will actually have a lot of headache, fatigue. A few people might report some dizziness. And I haven't really had anybody report insomnia, but I did have someone report abnormal dreams. Those usually go away after that month. So it's not something they have to live with. And for things that we can have medications for symptomatic relief, we prescribe them. So the thing that you should be aware of is regarding your windows. So if you're starting someone on oral PrEP, there's a time from you starting the PrEP to when you know that you have enough medication on board, especially at that mucosal area where you're having exposure, to say you have enough drug to protect you from getting HIV if you were exposed. Mostly it's a week. I tell people you have about a week before we know it's effective. Really, for rectal exposure, think about 2-1-1. If you take 2 pills up front, we know you're usually pretty good. But for vaginal exposure, we're just not as certain. We usually counsel people, it's about 3 weeks until we know that you have enough drug on board to protect you from HIV. And so during that time, we still strongly recommend using condoms if you have a heightened concern about HIV acquisition. And then we always recommend using condoms to prevent STIs. There's really not a lot of data on Descovy, and also insufficient data on cabotegravir to tell us what that startup window is. In regards to stopping, People can stop PrEP at any point in time. You don't have to be on PrEP for the rest of your life. I usually tell people if you stop PrEP, it gets out of your system after about a week. If they have hepatitis B, they might want to let their primary care provider know. And since that is you, you would say, I'm going to check your LFTs just for a brief period of time to make sure that you don't have a flare. But like I said, that is a rare complication from someone having hepatitis B and being on therapy. And then for injectable cabotegravir, even though this isn't a huge part of our talk, I will say the biggest thing that we tell people about is the tail. It has a long tail because it's long acting. So we watch people quarterly for 12 months when they get off of cabotegravir. So really, the amount of medication on board that you need that is the most protective, specifically for anal exposure, is 4 doses per week. That's how you know that it's the most effective. For vaginal exposure, we usually tell people it's best if you take it every day. And then the thing that I know a lot of providers get concerned about is this idea of behavioral compensation. So what happens if you start PrEP? Are people going to having more condomless sex? Are they going to engage in higher risk sex behaviors? And honestly, studies have been mixed. Some people have seen that after people start PrEP, they appear to have more STIs, but they're also getting more testing, which they may not have been getting before. So I think that the most important aspect that we have to remember as providers is that this is something that is a part of a good comprehensive toolkit. It doesn't replace condoms. And we just have to make sure that we're doing patient-centered care. And so we're talking to our patients about all of these options, and we're figuring out what is the best in regards to their goals for their sexual health. For adherence counseling, I give my patients everything. So I'm like, hey, set an alarm. If you have keychain pill dispensers, I give them keychain pill dispensers. I will tell them, if you have a behavior that you know that you do every day, like you brush your teeth and you're living alone, you're not worried about unintentional disclosure that you're taking PrEP, then you can put your pills next to your toothbrush. So you try to make sure that while you're talking to them, you're giving them some clues into how they can remember to take their medication. And then we should always address for any barriers, because this is something that requires you to come in every 3 months. So you want to make sure that you're doing things to screen for depression, unstable housing. And remember, the younger you are, the more likely it is that you may have issues or encounter barriers to adherence. And so you might want to have closer check-ins with those individuals. Okay. So we're shifting really to almost this last part of the talk in regards to prescribing PrEP. So we really found that specifically for youth, confidentiality is one of the most important aspects of their healthcare. And when you're talking to them about their sexual health and specifically about PrEP, hopefully you're doing it in a setting where you're getting some one-on-one time with them. The issue, which is there's good and bad, is that we have now the Cures Act. And so with the Cures Act, people have the right to have access to all of their health information. That's why we have patient portals now. With adolescents, that means that their patients and guardians a lot of times have access to that information. So unless you've already discussed this with your healthcare system and you have a separate pathway for minors to be able to access their health records, then we especially recommend for our adolescent populations before we start them on PrEP that this likely isn't going to be a secret. Explanation of billing comes into the mail. Their guardian or parent will likely find out that they're getting STI testing, HIV testing, or they may be able to even access their records. So it's important to discuss that up front. Say, I want to be a support figure for you as well. And so I've offered people to talk to parents if they're willing and talk to guardians if they're willing and see if they can be a part of that sexual health conversation with them. If they cannot, then you need to come up with ways to either try to protect them from that unintentional disclosure or provide them with resources and locations where they can receive care, sometimes at a local health department, where they will not have the risk of their patients, or sorry, of their guardian seeing that record. So we always tell people, know your state law in regards to minor consent. For us, it's the age 14, and you should have this on your badge buddy. If you can, separate and have a differential portal account access for adolescents. And then you want to have confidential note types, or the ability to designate notes as confidential if you can. In regards to billing and insurance claims, we do have some really easy billing codes. I will say, contact with a suspected exposure to HIV, contact with a suspected exposure to STI. These codes, unfortunately, are not the most friendly and destigmatized. Unfortunately, these are sometimes the codes that are necessary in order for you to get reimbursed for services. So I usually would let patients know, hey, you might see this billing code come in. This is what I'm using, just to make sure that we can cover your PrEP care. I strongly, and we strongly discourage using high-risk sexual behavior as a billing code, because that is really stigmatizing. And I don't know if you've noticed that we try to stay away from risk-based language within this talk. And then we always let people know, so Truvada is generic, and it's $4 at Walmart and Winn-Dixie. We also have some pathways that you can take in regards to whether someone is insured or uninsured. So again, if you're insured, Truvada, there's a generic option. It's a grade A recommendation. So with that grade A recommendation, we also have zero cost savings, and there should not be copays. But Gilead does have a copay program if necessary. For uninsured individuals, there is a PrEP assistance program. And Gilead has a medication assistance program, and we've given you the website for that. This is also an algorithm that you can walk down if you have a patient who's insured or uninsured, and some of the different options you have available to help with assistance in paying for visits or paying for medication. And again, I would strongly recommend, if there is this concern in regards to being able to offer this medication specifically due to cost being a barrier, there is generic, and it's $4. Medicaid in our state does cover PrEP. The only Medicaid that doesn't is if you have Medicaid that's only for reproductive or contraceptive purposes. This is what the Gilead Medication Assistance Program portal looks like. So we put up here the web address that you would have to put in, and then the actual link where it says download the enrollment form that you would have to click. And that's how you enroll into the program. There's also a national program called Ready Set PrEP. This covers Truvada and Descovy. So if you have patients where you have to prescribe Descovy, this is something that could help offset costs. You do need patients' insurance information for this, though. And then lastly, we provided you with some resources. So CDC has wonderful resources that can be a supplement to this talk. There's pleaseprepme.org, which is a great resource if you're looking for other PrEP providers that may be able to provide PrEP to adolescent populations if there's concern about confidentiality. And there's, of course, local CBOs as well. So any questions on PrEP prescription before we move on to some actual case-based learning? Okay.
Hey, this is Dr. Malhotra. It was
Yes.
excellent. It was excellent. It was very to the point. So thank you very much. My question is that, you said, so that means technically we have to have like a PrEP discussion with almost every sexually active person. Is that right?
Yes, you should. And it may not be that you're starting everybody on PrEP, but you're just making them aware that there is a tool that they can use that prevents HIV. It's a pill you can take called PrEP.
Yeah. But anyone who you said possibly had gonococcal or a syphilis infection, they have a little bit more probability of having it. Is that right?
That's right.
Okay, well, thank you.
And we have that decision tree, and we'll have these slides available for you on our website. So you can always go back and pull it back up if you ever want to reference back and look at specifically what are some of the indicators.
Okay, but you're going to send us these slides too, is that right? If I miss anything.
Yes.
Okay. And then you know that on our campus specifically, we don't use the same EMR. So we'll have to figure it out. Now, if it is an adult, and we do this conversation during their regular visit, do we need to open up, like, do we need to document into any other note? Or can we document in the same note?
You can document in the same note if it's an adult who has their own insurance. It depends on if they're under their parents' insurance plan. So a lot of people will be under their insurance. I can't talk today. Parents' insurance plan up to the age of 25. So I ask people, are you under, is this your insurance plan? Or are you under your parents' insurance plan? Because I've had parents call up and say, like, what does this mean? And I have to say, I can't discuss this with you.
Oh, so in case if they are on the parents' insurance plan, but if they're 14 plus in state of Alabama, we can discuss that separately and keeping it confidential.
You can, yes.
Yeah, so maybe we will probably have to open up. Okay, that's fine. We'll figure out our workflow at some later time.
These are great questions, though. And I think it's important because we had a community advisory board full of adolescents, and the biggest concern they had was confidentiality. Like, will my parents know that I talked to you about PrEP?
Yeah. That's the big thing. So I think keeping it separate as a separate note. But again, if you put the diagnosis, because if they agree to get tested, the diagnosis is still going to come on the claim form.
Right.
So there will be some kind of information will be shared with the parents without directly talking to them. But okay.
And that's why that's why I think when possible, and I understand it's not always, but I just tell people who are adolescents or under their parents' insurance up front, there's a chance that this may be disclosed. So it's, if you can, if you're in a safe space where you can have this conversation with your guardian or parent, that would be the ideal
You
scenario.
should have.
Yeah. If it's not,
but
then
again, we can
figure out ways to protect you. Yeah.
But again, did you have any examples where you order the test? Because once you order the test and the patients get the test done, like an HIV testing done, then if the parents, it'll come on the parents' claim. So say if it is not covered, well, probably testing is covered, but if they have to pay a copay, the parents have to pay a copay. Can they come and kind of, fight with you? Hey, why did you order the test without telling me? Because now I have to pay.
They can't.
Okay.
Yeah, I've had those scenarios. It's not a fun experience having parents, get angry at you on the phone, but I say this is something I actually do not have to disclose with you. I talk to your child about this, or your adolescent, or your young adult about this, and it was a confidential conversation. I can't discuss this with you.
Okay, so that's a great help. If we can have some generic answers so that everyone can say generic answers other than making something up which can cause trouble. Okay.
Any other questions?
I have two questions. One of them is, I guess, should I also be checking like vitamin D levels on these patients as well before I initiate, since there's that risk of the bone mineral density?
No, because we didn't see poor bone health in adolescent populations at all. So they're really fine. We don't have to check vitamin D. The only instances where we actually saw people have issues if they already had osteoporosis, and then in the trial specifically, it's called Discover, that included people either getting Truvada or getting Descovy, individuals who are over the age of 50 and usually who had a history of like smoking. So people that you would be concerned about their bone health anyways, like they had issues. So that's really the population that you should be concerned about in regards to bone health.
Okay. And then I guess it's just really those patients that I would potentially get a DEXA scan in sooner rather than like the recommended guidelines.
Right. And in those populations, if it's someone who is having anal exposure, so that's their route, if really anyone other than a cisgender woman, because that's who wasn't included in that trial, they can get Descovy. And then Descovy does not affect your bone health at all.
Okay. Perfect. Thank you.
You're welcome. These are great questions. Any other questions?
Dr. Elopre, I do have a question.
Mhm.
So have you had instances where the child is on parents' insurance plan, or the adolescent or young adult is on the parents' insurance plan? They have agreed, but for some reason, parents have questions and we give our generic answer saying, I'm sorry, I cannot disclose because it's confidential. And they say, well, if you don't tell me, I'm not going to pay for it.
I mean, I've had, so in the instances where I've had this happen, one was a person who was living with HIV and one was someone who was a PrEP patient. Honestly, unfortunately, the way our healthcare system works, like you can't not pay.
Well,
Or it goes to
again,
like collection agencies. Like this is something that was ordered and it was about to be clinically indicated. You know what I mean?
I get it, but let's say if the parent says like, yeah, I'm not gonna have you pick up that prescription. You cannot go get that refill or something
Yeah.
like that. In those situations, do we just leave it at the young adult trying to have that conversation with the parent and saying, yeah, I need this?
I usually circle back to my patient
Okay.
and I say, hey, I wanted to let you know. Because this is in regards to their health care. This
Right.
occurred in the future. This may occur again.
Okay.
How do you want to proceed? We can try. In one instance, unfortunately, it was in one of my patients who was a young gay man who did not have a good relationship with his parents. And they weren't very accepting at that time.
Okay.
He never wanted me to talk to them. And it was always contentious, like every time. But I just did what my patient's wishes were. So I said, okay. I said, we're ordering this. So I want you to be prepared for the questions you may receive as I order this. But I don't want this to stop you from getting the care and services that you need. And then also making sure that he was aware. So I told him, you could always go to the health department. They can't see my charges there. He did not want to go to the health department.
Got it. Okay. Thank you.
Well, what is the cash price of the medication in case you want these patients who don't want the parents to pay for the refills and all that stuff if they go take a prescription to Walmart, as you said? Is it $4 with insurance or $4 cash anyhow?
$4 cash.
Oh, okay. Then I think they can just go buy $4 cash if they don't want to talk to parents.
I hope so.
When do you kind of in your clinics with your experience make this kind of conversation, like during their well child visit with these young people, or like in our, once we start doing this, like with that, do we start kind of calling patients to come and visit us and have this discussion? Is it going to kind of screw up the study, or is it kind of completely randomized? Or
No, it's not going to mess with the study at all.
okay.
The whole study is just us trying to understand with these tools, does it make it easier? Is this helpful? So I think us understanding what you had to do to be able to actually effectively provide sexual health care and PrEP care is key. And then I will say, so you will have the opportunity to talk to Dr. Samantha Hill, who did her fellowship in adolescent medicine. That's kind of like what she does. And
Okay.
she'll be the ideal person to talk to about, especially have these conversations with early adolescents. I think she has prescribed PrEP to as young as 14.
Wow. Okay. Okay. Thank you.
You're welcome. Okay. Any other questions before I move on? Okay, you guys ask great questions. Again, you can always reach out to us, and we're going to go over one extra tool we have. So we're going to talk about what does it mean to be a PrEP champion. So in regards to being a PrEP champion, the reason why we think it's so important is because we want you to be the person that people can go to at your clinic and you're like, yes, we can do this. And I have all these resources available that will help us be able to do it. One thing we really want to focus on, number one, is why it's so important for you to be a champion specifically for PrEP. So we're going to talk about really inequities and PrEP prescription, which we haven't gone over with in the prior talk. Understand barriers to PrEP for women. And then we'll talk about what does it mean to be a PrEP champion in the study. And then we'll do some of the cases as people come in, what do you do? So right now in the US, they think that about 1.2 million people have an indication for PrEP, meaning this is the number of people in the United States that likely would benefit from PrEP based off of that decision tree that I showed you in the last presentation. But coverage has not been that great. Only 30% of those individuals are actually being prescribed PrEP, and only 10% of women. And if you look at who's actually being prescribed PrEP from a racial standpoint, the majority of individuals are white and a minority are Black. And so this is disproportionate to who we know likely will end up being diagnosed with HIV. So this is our inequity that we're trying to close the gap of. Because the concern is that if we continue to have these effective prevention tools go out to only our populations that have and are not facing the brunt of new HIV diagnoses, we may see widening disparities, which is not what we want. And this is true, really, even after you start someone on PrEP. So this is Kaiser Permanente. They were recently in the news because they had a strike. But before that happened, they had a cohort study where they looked at 13,000 individuals who had been linked to PrEP care. 95% of those were men. Only 7% were Black. 22% were Hispanic. And then they looked at who discontinued PrEP at least once. Over 50% at least once discontinued PrEP. And the majority of those individuals were Black who discontinued. So Black individuals compared to white were less likely to be prescribed. They were less likely to start, and they were more likely to discontinue, 1.36 times more likely. I want to just point out the last bullet, which is those who started and persisted with PrEP. So that actually was 0. So really just groundbreaking, I think, evidence to show why it's so important for us to be having these conversations. And then looking at from a population health standpoint, inequities and impacts, what this graph is really showing you is that why you care about this specifically in the Southeast. So I think I told you in the last presentation, the South carries the burden of the HIV epidemic. We have the most diagnoses, but we're the least likely to prescribe PrEP. Alabama specifically. But even in the Northeast, so look at this right upper quadrant. You're looking at something called the PrEP to need ratio, which is telling you how many PrEP prescriptions you have over how many new HIV diagnoses you have. The higher the PrEP to need ratio, the better. That means you have less unmet need. So in 2012, PrEP to need ratio, bad. It improved over time in the Northeast, especially among white individuals who are in the purple line. But you see that the gap between white and Black individuals widened drastically between 2014 to 2021. And this is just showing you proof of concept about what I mentioned just a second ago, that the disparities are widening within that region on who's accessing services. And then specifically, as I mentioned earlier, we know that those who are least likely to be prescribed PrEP are those who identify as female, and especially Black women. So the prescription rate is 6 times higher compared when you're looking at white individuals to Black patients, despite this group accounting for about 40% of new HIV diagnoses. So there's a lot of reasons as to why we see this. I mean, especially among Black women, we know that there's still low awareness about PrEP, which is why I emphasized so much in the last talk. We want everybody to know about PrEP, that this is an option. There's a lot of medical distrust due to current and historical past incidences that are traumatic for them. We know cost is a huge barrier, so we always want to be upfront in regards to cost. People are concerned about, is this safe? Why is this happening? And then there's a lot of stigma. So people will say, well, why are you talking to me about this? Right? HIV is stigmatizing. Sex is stigmatizing, unfortunately. And so for you to be able to say, I talk to this about all of my patients who are sexually active as a part of their sexual health toolkit, and I want you to feel empowered to meet your sexual health goals, is important. And you want to be able to say that honestly. So you are a PrEP champion as of today. You are an expert who is willing to seek out information about PrEP and streamline workflow. That is what a PrEP champion is. So in this study specifically, that means you're going to advocate for prescribing PrEP at your clinical site. You're going to lead development in regards to any protocols that you need to push forward if you find gaps or barriers to prescribing PrEP. If someone has a PrEP question, they should be able to turn to you as the main contact. You all should be able to talk to each other about any concerns or questions you have about PrEP. We do have a consultant as well that will help with that. You're going to learn about financial assistance programs that are available to help pay for PrEP. You're going to organize staff trainings for PrEP, look for opportunities to outreach and reach your community that you think might likely benefit from being on PrEP. And then the most important part is that if you hit a challenge, you're willing to troubleshoot and try to figure out how to meet that challenge and push past it. So the tools that you'll get specifically for this study is you're going to get the sexual history screening tool. That is actually a form that you can use if you'd like at your clinic, where patients can fill out on a piece of paper, did they have sex? Who was the gender of the people they had sex with? How many sex partners did they have? And did they use condoms? Then they hand that back to a medical assistant. So before you walk into the room, you can already see and discuss questions that they may have in regards to their sex, because you know at the minute you walk into the room whether they're sexually active or not. There is some data to show that people may be more willing to be honest doing an anonymous fill in yourself survey than talking to a provider because of concerns about judgment and stigma. You can post flyers in your clinic that we can provide about confidentiality, telling minors, if you talk to me, it's confidential. We have badge buddies that talk to you about how do you prescribe PrEP? How do you follow up for PrEP? And then what do I need to ask when I'm taking a sexual history, which you'll get in the talk next week. We do have a web page that Madeline will send you that will have all of these materials on it. And then we have a PrEP champion consultant named Michael Fordham, who's at 1917 Clinic, who's available to answer questions if you have them. You also pay for your study activities. And the main study activities that you have that you're paid for is training residents about PrEP. And that means taking a sexual history and prescribing. Meeting hopefully with your PrEP navigator if you have one, and that's really anyone at your clinic who can help you with insurance questions and file claims for you. And then any form of community of practice that you can form. So if you decide, hey, I'm going to meet monthly virtually with other PrEP champions from the study, that's something you can get afforded to you as a paid study activity. You can create a group me chat. So if you have questions that arise. So again, we want to point out the biggest thing that comes out of this whole form is that there is zero cost sharing that applies to PrEP, but that is only PrEP. No other healthcare service. So if you bill for another condition that is not directly associated with PrEP, then it may lead to additional charges. And that's why we pointed out in that one slide, and you'll have this on your badge buddy, the ICD-10 codes that we know usually are covered and reimbursed and considered PrEP associated billing codes. So for example, if you bill for erectile dysfunction, that's not going to be covered. Hepatitis B, that's not going to be covered. This is our PrEP champion, Michael Fordham. I want you to be aware this is the clinic in which we all work and share space. You will have access to his email address. He is wonderful. Please reach out to him if you have any questions about prior authorizations, insurance questions, anything that arises. He's probably going to be able to answer for you or connect you to somebody who can help you. Okay. So we're getting into case-based learning. Tiffany is a 20-year-old female presenting to her PCP, complaining of a painless ulcer she noticed on her labia 2 days prior. She denies having any other symptoms. Sexual history, she reports one sex partner in the past 12 months. They don't use condoms anymore, and they engage in vaginal, anal, and oral sex. She has noticed no other lesions on her partner. Tiffany has STI screening and is positive for primary syphilis. You treat her with penicillin IM, and she expresses concern about how she got this STI. How would you address her HIV prevention needs? So what would you offer to Tiffany now? Anybody?
I think it's hard to answer her concern of how she got this because it's a relationship thing. So we really can't talk a lot on that, but we can educate that with her having history of this specific infection increases her risk of contracting HIV in future. And so counsel her in terms of how different modalities can help, along with using a barrier protection and possibility of offering her to be on PrEP, even though she's with one partner, but because of her history, she might be at increased risk.
That's great. Does anybody have anything else to add?
Well, again, this is Dr. Malhotra. A 20-year-old, like in our clinic, when we say STI screening, it includes your RPR, GC, chlamydia, TRAC, but that's like depending upon their risk if they're high risk. But we offer HIV to everyone. So if this is my patient, she would have already gotten an HIV screening because it's a universal screening according to the task force guideline from 16 to 65. So all my 16 to 65 years now get HIV screening anyhow. So how do you deal with it? Like say if her HIV screening came back negative along with her STI screening, is it difficult to convince them to get on PrEP?
So we're going to get to that. We're going to keep following Tiffany, but
Okay.
Hopefully it would not be difficult. And I think we would want to frame it with Tiffany as she's established a relationship where she feels like she can talk to us about this now. And Tiffany, is this something that you think would benefit you in regards to HIV prevention after you've educated her about what PrEP is? A lot of times in the back of our minds as providers, we're like, yes, we really want you to do this. This is why. But if you communicate to that in that fashion to patients, it can be very stigmatizing and they're actually not going to do it. You need to understand what their goals are and try to work within those goals. And hopefully if they're educated about all the options they have available to them, then maybe PrEP will be one of those goals. So I think you guys were spot on. Does anybody else want to add anything? Okay, so yes, we definitely would have hopefully also done a comprehensive panel that included HIV testing for Tiffany. And this is something that's real. A lot of times in these scenarios, especially when people report one sex partner, which is very common, their biggest concern because this is dealing with relationships, is how did I get this? The important part is to focus on the facts. This is something that is sexually transmitted. I can't speak about your partner and that aspect of your relationship, but what I can speak is about your sexual health and what we can do for you today. Luckily, this is something that is treatable at this point in time. And I think that what you want to do is be able to offer her sexual health counseling where you can say, based off of what your goals are in regards to whether you want to have a pregnancy or not, and based off of your goals in regards to what you think you're capable of doing in regards to HIV prevention, what can we offer for you? So yes, we would have wanted to, at this point in time, done HIV testing for Tiffany. We would have said, you had this exposure on this date. So if Tiffany had an exposure 2 weeks ago and we did an oral swab, that may not have picked up her HIV infection if she were to actually have been exposed and acquired HIV. And that is what this is testing us about. It's just showing us the window for testing. So hopefully we have done antigen antibody testing. And then if we're talking to her about PrEP, we can check a nucleic acid test or viral load. Within that 2-week time frame, this should pick up an acute infection. So for Tiffany, I would say if we had a viral load on her, I can feel confident if it's negative that you do not have HIV. The other thing that we would want to do is take a more thorough history. So that means for Tiffany, yes, we would say to her, based off of the fact that you did get syphilis this time, this is something that we know for a lot of individuals can lead to potential future diagnosis of HIV. And there are tools that we have available that are effective at preventing HIV. Based off of where you are in your life, if you feel like you can't take or use condoms every day with every sexual encounter, which is okay because a lot of people are not able to do that, or they don't want to do that, then there's something called HIV pre-exposure prophylaxis or PrEP that may be something that could be an offering for you. So you talk to her about PrEP, you take a very thorough sexual history, you assess her interest and readiness to start PrEP. And a lot of times this may take several appointments. So this may not be like a one and done. Our pilot is short, and it's okay if you only just start engaging in conversations with some individuals about interest in regards to PrEP, because sometimes it takes people time. I think that the thing that is important to remember that is especially for individuals that we know have networks that are dense, meaning that they have sex with individuals who are within the same location, and those individuals have sex with the same other individuals. So typically for Black gay men, they have dense sexual networks, especially in the South. They have a higher likelihood of being diagnosed with HIV. And if they've been diagnosed with syphilis, the likelihood of them being diagnosed with HIV within a year is 50%. So it's pretty high. So you're going to want to follow up with them pretty readily to assess willingness and potential readiness to start on something like HIV PrEP.
Can I interrupt? On the slide, when you said about the testing, so the testing you do is antigen antibody test, or you do a viral load on everyone before you start PrEP to confirm?
So we require antigen antibody test. The CDC guidelines now say that for you to do follow-up care, you have to have a viral load. Some people, yes. So some people, depending on that window, will check a viral load depending on when that sexual exposure was to actually say someone is negative.
So you do your rapid, you do your antigen antibody test, even if it is negative, but they're willing to consider PrEP, you should do viral load before you start PrEP. Is that correct?
Only for follow-up visits.
Only for follow-up?
Yes. So, the viral load has been recommended for for follow-up visits because of that concern of breakthrough infections. So the only time that you have to give, you say antigen antibody plus or minus viral load for that initial is based off that window. If they have acute signs or symptoms concerning for HIV, or if they're like, you know, I had sex 2 weeks ago, an antigen antibody test may not pick it up.
Okay. Okay. But you know, again, PrEP is completely contraindicated if they have an acute HIV infection. Is that correct? Is that what you said in the previous line?
I'm sorry, what was the question again?
I said PrEP is you said PrEP is contraindicated if they have active HIV infection.
Yes.
Okay.
So that's why it's important to know this slide about your windows, because we don't want to prescribe PrEP to anyone who has HIV. So if they have acute signs and symptoms of HIV, then for those individuals, we typically will say, okay, we can check a viral load. A viral load can pick up HIV. We say safety 2 weeks, but our experts who have done multiple clinical trials usually say you have about a 5 to 7 day window with a viral load to pick up an acute infection. Any other questions? Okay. So these are the lab tests that we talked about in the last. So for Tiffany, we would want to check our hepatitis B and our STI testing as well, and check that creatinine. And then support medication adherence. So let's go back. We've talked to Tiffany. We've said, okay, we think that PrEP may be something that you could benefit from based off of your goals that we just discussed. Does anybody want to talk about or run through a scenario on how you would actually counsel Tiffany in regards to side effects and how she can start PrEP and be adherent to PrEP based off of what we discussed in the last talk?
I guess I'll go. But one thing that I will say that in my first, when we talked about Tiffany offering her PrEP probably was not the best thing to start with. I think first understanding where she's coming from, what her goals are, is our first step. So after we have done that, if she is agreeable to it, then we'll say, okay, we can start PrEP after we have done the initial testing today. Then she comes back whenever, let's say, we'll do all the testing today. If everything comes back negative, we are going to give her a prescription to start the PrEP. We're going to tell her that since she is engaged in both vaginal, anal, oral sex, as far as the anal sex goes, she should be the medicine will be good enough to prevent her from anything in about a week. But with her vaginal exposure, she still needs to continue to use barrier protection for about a month before she can be assured that her levels are good enough to prevent her from having any of the exposure. And then she will come back in 3 months for follow-up, at which time we'll do the STI testing, do the RNA levels and viral load testing. And then thereafter, she'll continue every 3 months. And if she ever plans to stop, she can stop it. It takes about 7 days for her to get rid of the medication, which is the washout period. And that's it.
Wonderful. That's great, Shruti. Thank you. Does anyone have anything else they'd like to add? Okay. So the only thing that I would add is regarding tips and tricks to help with adherence, and then reviewing side effects. So a lot of people will be concerned about side effects. That's one of the biggest barriers to people wanting to start PrEP. What would you tell Tiffany about side effects?
Pretty much every medication we prescribe has side effects. Nausea, vomiting, diarrhea is the most common side effect with everything. So she should possibly expect that to happen, but it's going to go away after she has continued using the medicine. It might take 2 to 4 weeks for it to be completely gone away. But the other side effect that she should be aware of is the abnormal dreams. So if she's having some vivid dreams, be aware that the medication could cause it. And if it's not getting better or not going away completely at the end of 4 weeks, just let us know and see if we can do something. Or if she wants to continue at that point.
Okay. That's great. Those are really the most common side effects. Now, this study is focused primarily on Truvada. The other option that I discussed briefly with you is Descovy. Does anybody remember what the side effects are and what we look for with regards to Descovy? They're so quiet. Can I call on somebody? Stephanie, do you remember?
Stephanie said she was unable to use her audio right
Oh, okay. What about Joel? Oh, Stephanie she typed in the answer. That's great. Yes. So weight change is one of the things that can happen with Descovy. So I usually do counsel my patients that you can get some weight gain. Usually it's only within the first year of taking it. Joel may not have power right now.
Was that the one where we check for Hep B as well and kidney function?
This is great. So you check at baseline for hepatitis B and kidney function for both Truvada and Descovy. But there's one thing that you check for Descovy that you don't check for anything else. And that's lipid panel.
Yeah. Sorry, I was about to say that.
Oh, I'm sorry, I stole it. Great job, Ashley. Yes.
I actually have one other question, if that's okay. I want to ask before I forget, but I'm sorry to interrupt your good flow. So do you ever get, in reference to these side effects, I know that your PowerPoint so far has done a good job about the mainstays and what we need to do as providers, but do you ever, what is common if you ever get the old, so I read on Google and it says this, right? Because our resources are usually not Google, right? They're up to date, they're accredited. Do you get anything like common that people find on certain websites that aren't these things that are kind of like out there?
That's a great question. People will say, I saw on Google this is going to affect my liver. Then I'm going to get liver failure. I don't know where they're finding that on Google. I don't know if they're looking at other ART regimens and very old school ones at that, but that is a really common thing that I'll hear. And I'm always like, no, I don't even check your liver function. Like, you're fine. That is not something we're screening for. I think that the other big thing that people usually come in with, if they're going to say anything, is regarding Truvada and the kidneys and the bones. So I'm not going to get on a soapbox about this or anything, but Truvada is generic and Descovy is not. And a lot of, I mean, it's not a secret. Truvada was held for a long time until the patent was going to be going up, and then Descovy was released. Ultimately, coinciding with that, there was a lot of commercials and lawsuits that came out, really flooding the airways about the horrors of Truvada. Truvada is not a bad drug. Very few people have issues. So I tell my patients, like, there's very few, but like one person had one kidney. I said, maybe we shouldn't put you on Truvada. I've had some people who, like I said, were older, who had history of smoking. I said, we probably shouldn't put you on Truvada because I'd be concerned about osteoporosis in you, and this can affect your bone health, especially for older individuals. There was one individual who had poor kidney function, who was overweight, who smoked, and had hyperlipidemia. For that individual, I actually said, you should probably go on cabotegravir. And again, that's the long acting option. We did not go over that because there are issues in regards to being able to get long acting injectable into the clinic. But if that's a person or a patient that you encounter, then we would be more than happy to help you if you want to provide cabotegravir for them. Because that is something is rare. It's happened to me one time, but it did. And I said, I think you should get on cabotegravir. Any other questions? Okay, so you guys were spot on. All the things you want to do is you want to support adherence. And really, when it comes to supporting adherence, we're talking about things like, hey, I want to give you upfront information about side effects. I want to make sure you're aware. So if you encounter them, you're not like, oh, I'm going to throw this away. I'm going to stop this. It's hurting my body. Like, you're prepared. We're going to still make sure that Tiffany feels like she's empowered to be able to talk to her partner if she wants to, or talk to her guardian if she wants to, and not feel like this is something she has to hide. And then we're going to give her upfront information about what does it mean to be in PrEP care. So that means you'd be coming in every 3 months, and we might be asking you the same questions, checking in about how you're doing with the goals we discussed today, so on and so forth. Okay, so now, same case, you start Tiffany successfully on PrEP. So wonderful job. You were able to do something that 90% of individuals have not been able to do. So you start someone on PrEP, and she is excited that day, but then you come back and you talk to her and she says, hey, I've only been taking it like 3 times at most a week. I've been forgetting. What would you say to Tiffany then? Would you continue her on PrEP?
Yes. I would encourage her to take it daily, but with Truvada, I think we said 2 doses per week is good enough to keep it at a good level to prevent HIV. And then for Discovery, it was 4, or I have it flipped in my brain.
So this is why I'm bringing this up. This is great. So I don't want you to feel discouraged. Ultimately, for vaginal exposure,
Okay.
you have to take it really
Every day.
every day. It's like birth control.
Right.
I tell people it's like the oops baby, with birth control. You're like, oh, I thought I took it every day, but I noticed there were some extra pills in the pack. It's unfortunate, but that's kind of where we are with PrEP for vaginal exposure. So
But if it was for only anal exposure, then 2 doses per week would still hold 4. 4 doses would hold. Okay.
So now that you know that she's not really protected, would you still tell her to continue?
I'll probably ask what are the barriers in terms of forgetting. Is it just her forgetting, or there was any other reasons why she was not able to take, whether it's lifestyle, whether it's cost effectiveness, and try to address those and see if she can still take it every day. If she wants to continue and we can overcome those barriers, advise to take it daily. If not, then at least encourage her to do the 2-1-1 dosing is for Discovery. So that's not possible with Truvada. Then basically do a shared decision making as to what would her goals be.
Great, that's fantastic. So 2-1-1 is for Truvada, but it's only for anal exposure. So this is why we bring this up, because for vaginal exposure, unfortunately, right now, you really have nothing in regards to options for oral, except for kind of taking it every day. Cabotegravir could be an option for her, but yes, we want to say, what are some of the reasons that it was difficult for you to take your pills? Let's walk through what the barriers were. We don't recommend that you stop. And Trupti did a great job with that. Ultimately, a lot of people, especially in studies that have involved cisgender women, report that persistence is an issue. Sometimes it's just remembering to take a pill every day, which is actually super hard. So going back over tools, saying like, let's set a phone alarm. Do you have a daily pill dispenser? All of the tricks that we talked about A lot of times people don't implement it the first time, but they may implement it the second. Talking about why, if there's an actual reason in regards to risk perception. Maybe Tiffany's back in a relationship now and she says, I don't feel like I need this anymore. Ask about why she's saying that and what are the dynamics of that relationship that make her feel comfortable saying she doesn't think she needs PrEP. In studies that have included gay and bisexual or other men who have sex with men who've discontinued PrEP, there have been several that have shown that a lot, unfortunately, have seroconverted after they've discontinued. So understanding and risk perception is a huge thing. Sometimes it's unintentional. We always want to support restarts and just make sure that stigma is not the barrier. And if it is, walk through what is causing that stigma for her. So all of the things you talked about, Trupti, we want to assess barriers and make sure that we're bringing her back in frequently and we're just talking with her. If she's continuing to miss, I think ultimately the other things that we want to make sure we are advising her of is that there's still a chance that if she were exposed at this time, she could get HIV and that virus could be resistant to Truvada. But there are options. That wouldn't mean that we couldn't treat her HIV. We would still be able to treat it, especially if she was on oral Truvada. So you guys did a great job. That is our case. Ultimately, there are tons of different other websites and tools that are available that help with how you can dispense every 6 to 12 months, how you can talk about discontinuations. We have other modules that talk about something called DoxyPEP, or doxycycline post-exposure prophylaxis. So a lot of fun other modules, if you're interested, are available on these websites. Feel free to access them. From our standpoint, we feel like hopefully we've provided you with a lot of information and tools today that make you feel more comfortable in prescribing PrEP. And please remember, if you have questions, this has been recorded. We will give you the slides. And you're going to have the badge buddies and our PrEP champion, Michael Fordham. So any last minute questions before we end?
I wanted to ask a question about, so the PrEP champions, to start the process, they have to wait for another training or they can start from now?
We really want you to get the second sexual history taking training as well.
Okay. So that's when they will, plan everything, and that's when they start kind of, okay. So how are the PrEP champions, Dr. Ford and Dr. Parikh are PrEP champions for my campus. How do you recommend them to keep track of their time?
Go ahead, Madeline.
Okay, so we have on our website a PrEP champion tracking log, which is basically an embedded Google form that populates into a Google Sheet for us. And so I will go through probably at the end of every month, and I'll be sending a Greenfire Clin card, which is basically a Visa debit card that we can load money directly onto. So I can either send that to their houses or to the clinic for them to get there. It's up to you guys how you want to allow that.
Okay, so just there's a Google form. Okay, so probably they can access it and see. Sounds good.
And you can record also in that Google form this training session today and the training session next week and get reimbursed for that as well.
Okay, sounds good. Thank you.
You're welcome. Any other questions?
Just a compliment. You did a great job.
Thank you. I appreciate it. We really want you guys to feel like you can reach out to us if you have any questions whatsoever. I'm very passionate about PrEP, so I don't mind if you reach out if you have any questions about prescribing. And Dr. Hill's also a huge advocate, especially in regards to adolescent care and sexual health. So you're really going to enjoy her talk, I'm pretty sure.
Thank you.
All right. Thank you, everybody.
Dr. Elopre, I have one last question, please.
Okay.
Let's say if somebody comes in who you have been was on PrEP for, let's say, one follow-up, and at the first follow-up they seroconvert and now they're HIV positive. Since they have been on Truvada, there is some concern of them being resistant to that particular medication. So in those patients, I know we refer them as a primary care, we refer them to the HIV clinic for treatment and all that. But do you ever do the genetic testing to see if they're resistant to Truvada before you put them on the treatment?
So for everyone who's newly diagnosed with HIV, we want to get a genotype because you can even get HIV viruses transmitted to you that are inherently resistant as the wild type. But regardless of that, if they were resistant and they were on Truvada, the most likely mutation they would have, say M184V mutation, you could still put them on Biktarvy. So that's why I'm not minimalizing seroconversions on Truvada, but they can still get good single tablet regimens, even if they were to seroconvert because of Truvada. For cabotegravir, you can get a single tablet, but it's a big one. It's called Simtuza. It's a protease inhibitor. So that's a little bit more.
Okay.
Yeah.
Thank you.
You're welcome.
How often do you follow up? Like if you start someone on PrEP, the first visit is maybe a month and then Q3 months, or?
In the beginning, we would actually do more frequent visits, but now a lot of people will just do every 3 months, even after you just start them. So I think really what used to happen is you would do a visit 1 week after, and then you do it every 3 months. But a lot of people, because of the burden to the patient, a lot of patients weren't making that 1 week follow-up. They just do it every 3 months, and they might just do a phone call where they check in after a week or two to just say, hey, how are you doing? You have any side effects?
Okay. And what are the goals for the study where we are looking to collect the data? I just wanted to be a little bit kind of proactive so that we plan accordingly in the EMR, what data we want to pull after that.
So we're going to look at HIV and STI testing and then look at PrEP prescription.
Okay. PrEP prescription and the testing.
But the major outcome, because this is just the pilot, is really coming back and talking with you all and saying, like, did you find this feasible? Was it acceptable? What can we do better?
Okay. But on our campus, what we are looking for is how many PrEP prescriptions we generated in next 6 months. Is that right?
Yes, that's one thing that we'll be looking at.
One thing. And then the residents are going to do the survey, and that's another, the behavioral changes or the support kind of provided to the physicians. Okay. Sounds good. Okay.
Any other questions? Okay, thank you, everybody. It was a pleasure.
Thank you.
Thank you so much.
A follow-up email to everybody at some point early next week, and then again after our next session of training next week.
Okay. Thank you,
everybody.
Bye.